Welcome back. We are on to our third principal component of pharmacokinetics. This is drug metabolism. I don't know why I messed that up. My bad, guys. But so far we have that the drug has been administered and absorbed. The drug has then been distributed to its sites. Some of the drug experience depot binding, and we are now to drug metabolism. So, again, drug metabolism is the biotransformation and elimination effects bioavailability. Okay? So, in other words, drug metabolism is the breakdown of the drug, and the drug can then either go on to bind in different sites, or it can be brought or leave the liver and get prepared to leave the body. Now, why drug metabolism is important is because not all drugs enter the body in an active form. So some drugs, especially oral drugs, we administer them in an oral fashion because we know that they're going to be metabolized before they enter the bloodstream. So we will purposely have a drug that needs to be metabolized in order for it to be an active drug that can then go on and act how we want it to and cause the correct drug effects. Well, this is going to become more clear as we talk about it, but in general, let's talk about drug metabolism. So this metabolism will primarily occur in the liver. Almost all drugs are metabolized in the liver, and it's done so using these microsomal enzymes. Now, we're not going to talk about all the enzymes that are used, but there is a big family of enzymes that I do want to talk about. So these are the cytochrome P450 family, and these are the enzymes that oxidize the majority of psychoactive drugs. So these would be opioids, antidepressants, amphetamines, etc. So you can see some examples of these drugs. You can also see some examples of enzymes that inhibit or different how these enzymes can be inhibited. So for instance, we've got this enzyme CYP3A4. So this enzyme specifically metabolizes these opioids, antidepressants, and anxiolytics, which is great. But if you drink grapefruit juice is kind of weird, where it actually prevents this enzyme from breaking down these drugs. Now, what that can mean is it allows these drugs to actually act longer, so they're able to stay active longer and actually move out of the liver into the bloodstream and go be active again, rather than being broken down. So that's why sometimes when you take drugs, then there'll be instruction like, don't eat this or don't drink that within so long, and that's because they don't want what you eat or what you drink to affect the drugs. So you might have seen that, thought we'd include it. Metabolism is a non-specific detoxification process, and then it occurs in two distinct types or phases. So here where I have type 1, type 2, you can also call it phase 1, phase 2, okay? So type 1 or phase 1 is non-synthetic modifications, so this is oxidation, reductions, and hydrolysis, and then type 2, phase 2 is synthetic modifications. Now, these modifications, whether it's type 1, type 2, or phase 1, phase 2, can be very important for some drugs, because remember how I mentioned some drugs need to be metabolized to be turned into an active drug that can then go on and cause effects, right? So a type 1 metabolism during a first pass can produce these active metabolites of the pharmaceutical preparation of drugs. So that's what I was talking about. So we see that here sometimes, so here's some active drugs. You can see how they get metabolized and then they turn into different drugs. Now I'm not going to read them all. You can kind of understand, for instance, with aspirin, it gets broken down before it becomes the thing that actually causes the drug effects. Okay? So that's where we get these metabolic products that are returned into circulation and can target sites of action. Now, sometimes, say with aspirin, it gets in phase 1, turns into an active product, and then in phase 2, so it goes and acts, and then it gets metabolized a second time into something else, which will then be moved to a site for excretion. In other words, it's no longer active, or it's no longer needed for its use. Okay? So that's why we have these biotransformations, and that's why some drugs are made specifically to change to be active so that a patient can take it orally. Here's an example if you want to see a chemical structure of what that looks like. So this is just the drug Zocor. So the pharmaceutical preparation is this lactone form. It's hydrophobic. It gets broken down in phase 1, and you can see that the change that's happening where it's metabolized occurs right here. So we see that right here, and what happens is it's hydrolyzed in the liver to the bioactive acid form. So now it's hydrophilic, and it can go on and do what it needs. Now, like drug administration and drug distribution, there are of course different factors that can influence our metabolism of these drugs. These are just 4 of the big ones. First is our enzyme induction. So this is where drug tolerance can occur. And so repeated use will result in an increase in liver enzymes. In other words, the more you take a drug, the more enzymes to break down that drug your body will create. And what that does is it means you can now take more and more of the drug before you see the effects or before you have long-term effects, because you have more enzymes breaking things down. And so this contributes to tolerance and cross-tolerance. So we will see this, for example, in people who smoke cigarettes. We actually see an increase in this specific enzyme CYP450 activity, and it actually increases the breakdown of drugs in smokers. So that's why smokers will then need, say, 2 or 3 cigarettes instead of just 1 to get the same feeling. Or why they may now need to smoke more frequently throughout the day, because the drug that they smoked isn't in their body as long. The second factor that can influence our metabolism is enzyme inhibition. So that means we may have some drugs that inhibit the enzymes from doing their job. Now, we talked about that a little bit with that example with grapefruit juice, but we also have drugs that are specific to inhibiting the breakdown of other drugs, or even the breakdown of neurotransmitters. So a great example of that is MAOIs. So this is monoamine oxidase inhibitors, which are used a lot of times for antidepressant, anti-anxiety. And what these drugs do is they inhibit the breakdown of monoamines. So monoamines, an increase in monoamines, you get an increase in mood. Okay, so by preventing the breakdown of monoamine oxidase, preventing the breakdown of monoamine by monoamine oxidase, then you now have more monoamines in your system. They can go on and act on the brain more frequently, leading to an increased mood. Now, the third factor influencing our metabolism could be drug competition. So if you're taking too many drugs, so like different types of drugs that need the same enzyme to be broken down, then sometimes there's just not enough of the enzyme to break everything down in a safe fashion, in a safe time. So that's why some drugs we say have you don't want to take together, because they will compete for binding, and then they'll compete for being broken down by these enzymes. And this can lead to different negative side effects. And then our final factor is, of course, individual differences. So yet again, we see differences in age, sex, but now also genetics. So some people just have different metabolic enzymes. Some people just naturally produce a different amount of these enzymes, and they're really just individual differences. Now, finally, we've got the last letter of our acronym. The last principal component is excretion. It's pretty much exactly what you think it is. It's getting rid of the drug, getting the drug out of your body. So the roots of excretion are breath, sweat, saliva, feces, breast milk, and urine. Notice that does not include vomit. When you puke up stuff, like say you drink too much and you puke, that's not really excretion of the drug when we're talking about pharmacokinetics. It is still excretion, but not in pharmacokinetics. And so why puke is not included on this list is because it's an unmetabolized drug. When you puke it up, it hasn't really had time to be metabolized. So that's why we're not counting it here, okay? So in all of these excretion methods, then it has already been metabolized. So our drug has been metabolized by the liver. The liver is now going to put the metabolites into the blood, and the blood's going to send it to where it's going to be excreted. Now, usually it's going to go to the kidney because most drugs go to the kidney and are then, peed out. But it can be expelled through other methods as well. So most drugs are excreted by what we call first-order kinetics. So this means that the drug leaves your system via half-life, or think of it as exponential elimination, okay? So it doesn't leave in a linear manner, it leaves in an exponential manner. Now, there are very few, a tiny number of drugs that do leave your system in zero-order kinetics or in a linear fashion. One of those drugs is alcohol, and that's why we see why alcohol tends to have an effect for a longer period of time than other drugs, and that's because it is leaving your system linearly rather than exponentially. But again, most drugs leave your system exponentially or in that first order kinetics. So this is just a fun graph showing that first order kinetics, showing how you have 100% of the drug at time 0. By 1 time 1, you have 50%, time 2, 25%, and so on and so forth, all the way down. So every time period, you lose half of the last time period. Okay? So by 6 time periods, so right here, by 6 time periods, the drug has reached less than 98%, the drug has reached about 98% clearance from the body. So you have less than 2% left in your body. So we usually say that by 4 to 5 half-lives, you'll be sober, but it's usually by 6 half-lives that you're like completely sober, or immeasurable. So here's a fun table of a lot of half-lives of some of the common drugs you guys might want to know about. So nicotine or tobacco has a half-life of 2 hours. So 2 hours after a smoke, you'll have 50% of that nicotine left in you. 2 hours or 4 hours after you smoke, you'll have 25% of the original nicotine in your system, so on and so forth. So if we take any of these half-lives and multiply it by 6, that's about how long it'll take for the entire amount of the drug to leave your system. So with nicotine, if we take 2 hours times 6, that means it's going to take 12 hours for one cigarette to fully leave our system. Okay? Now, here's just a fun summary of everything we talked about today. So this is going from administration and absorption to distribution and depot binding, metabolism, and excretion. So look at this summary. If there was anything you didn't understand, go back, look at it again, watch the video again. If you still don't understand it, please send me an email. But this is a great summary slide just describing the main points of what I want you to remember.